did medical school here in the University of Calgary. There's internal medicine and cardiology residents here, and he's been very productive also on the research front. He did his, he's doing a advanced cardiac imaging fellowship there at the Houston Methodist Hospital, the DeBakey Heart and Vascular Center. He's been focusing on interventional structural disease echocardiography and cardiac PET and CT. He's had some research and clinical fellowship funding by the our Arthur Child Fellowship, and he's doing some active research in acute hemodynamic changes in patients undergoing transcatheter mitral valve repair and the role of myocardial blood flow reserve in patients with aortic stenosis. And it's a pleasure to have him today. So, Payam.
Thank you very much. I'm glad to be back. It's amazing to be among some known faces, and thank you for having me for the grand rounds today. So today I'm hoping to speak about multimodality imaging in valvular heart disease. I'll do two case presentations with some discussions, focusing on complex mitral valve disease and complex aortic valve disease, and then talk briefly about the importance of dedicated heart valve team and the role of the team in patient management and patient care. So let's start with a complex mitral valve disease. Kate is actually a patient that I was very much involved in her care. She's a 92-year-old female that presented with several weeks of progressive dyspnea and lower extremity edema. She had a history of hypertension, atrial fibrillation, history of breast cancer, and no known heart disease. She was very independent. She was very physically active, and until about a couple of years prior to her presentation, she was actively playing tennis. She admitted to hospital with acute decompensated heart failure. And this is the first initial echo that was performed in our facility. I'm not sure if there is anybody that would like to address the echo, or if you have any comments, please just go ahead and unmute yourself and explain. But the top left image shows the bileaflet prolapse with a very eccentric regurgitant mitral jet. The top middle image shows the apical 3 view with bileaflet prolapse again, and then if you look at the anterior leaflet of the mitral valve, there is an echo density that's moving kind of freely in the LV cavity, suggestive of a flail cord slash potentially ruptured pap muscle. Looking at the apical 4 in the bottom left, you can appreciate the severe eccentric mitral regurgitation jet, and the Doppler assessment of the jet showed a very triangular jet, very dense, suggestive of severe mitral regurgitation. As part of her workup, she underwent a TEE, and her TEE again confirmed the finding that this is bileaflet prolapse. There is a flail cord, and as you can appreciate, there is you can appreciate the flail cord and the potentially ruptured piece of the pap muscle attached to the tip of the cord, although it's hard to appreciate. The MR jet is very eccentric, posteriorly directed, and that goes with the pathology of the anterior flail. This feature overall was typical for Barlow's disease when we did the 3D imaging. And here is the 3D imaging, which confirmed the severe flail segment of the A2 scallop of the anterior leaflet, and you can appreciate all the cords that are popping up into the left atrium. So this is the clinical summary so far for this lady, which is, as I said, is a 92-year-old female with decompensated heart failure due to severe MR and A2 flail. She has Barlow's disease, and despite being showing some clinical improvement with aggressive diuresis, she remained very, very dyspneic. So my question for the audience is, what is the best treatment option for her mitral regurgitation? And I appreciate if you can comment or unmute yourself.
Payam, maybe for those of us not attuned with all the four-letter acronyms, I take it TEAR isn't that you should cry because of her bad.
TEAR is not cry, sorry, apologies for the acronym. So TEAR is a transcatheter edge-to-edge repair using MitraClip. TMVR is transcatheter mitral valve replacement / repair. And then we have surgery and medical management. Apologies for the acronyms. Thanks, Satish. On chat, we have MitraClip from Dr. Murillo. Anybody else? I'm not sure if we have any of our cardiac surgeons on the talk, but yeah, curious to hear whether anyone is interested to taking this lady to OR for repair. Okay, I assume that's that no. So for this lady, her STS score was calculated to be extremely high. Isolated mitral valve repair for the risk of mortality was close to 10%, and isolated mitral valve replacement, the risk of mortality was 11%. So that brings us to the options for helping this lady who was pretty much asymptomatic, completely independent prior to her presentation. The three options is surgical repair and replacement, as we discussed, transcatheter edge-to-edge repair, or a transcutaneous, like transapical / transfemoral approach for a valve in native valve. Other transcatheter options for mitral prosthesis for valve in mag, valve in ring, and valve in valve. We will address them briefly at the later part of the talk. So what do we have for transcatheter edge-to-edge repair using the MitraClip device? The evidence that we have are from two trials, Everest 2 trial and COAP trial. Everest 2 trial was a trial that was done mostly for primary mitral regurgitation, with evidence of improved in symptomatology, heart failure status, and left ventricular systolic function overall in general, but no change in mortality. COAP trial was using the MitraClip device in patients with secondary and functional mitral regurgitation, and the COAP trial showed mortality benefit, reduction in hospitalization, and improvement in quality of life. Interestingly, the AHA guidelines adopted the technology pretty quickly over the span of past 7 years. This is the AHA guidelines for valve disease for severe mitral regurgitation in 2014. And as you can appreciate, the only therapy option at that point was mitral valve repair using surgical interventions. This is the current algorithm for primary mitral regurgitation. And as you can appreciate, there is a class 2A recommendations for mitral valve repair using transcatheter edge-to-edge repair technique in patients who have high or prohibitive surgical risk. And it's even more interesting to appreciate that the secondary mitral regurgitation now has a class 2A indication for mitral valve repair using the transcatheter edge-to-edge repair technique compared to a class 2B recommendation for mitral valve surgery in patients with functional MR. These are the current devices and prostheses available in different stages of trial currently in the United States. The only FDA-approved device is the MitraClip in the panel A, and the CLASP trial is using the Pascal device, which is figure B, which is a very similar technique to the MitraClip. In the world of TMVR, the Intrepid valve is currently under investigation in Apollo trial for valve in native valve and valve in MAC at this point. So what about procedural planning for this lady? Assuming that we are trying to proceed with an intervention in this setting. So we require a comprehensive transthoracic assessment to assess the mechanism, primary versus secondary, which was performed in this setting. Look at the anatomy, and especially look at the calcification. The presence of extensive calcification, it is important because that precludes us from proceeding with transcatheter edge-to-edge repair, and also confirming the severity. Comprehensive TE is also required to confirm the findings of the transthoracic findings, and also assess the feasibility, assess the 3D anatomy, and then assessment of the intraatrial septum. I left that image in this setting to highlight the importance of the careful assessment of mitral regurgitation and overall putting everything together. This is the case of a severe MAC, which on transthoracic echo showed a very light jet for mitral regurgitation. However, on further assessment, patient was found to have at least moderate to severe mitral regurgitation on transesophageal findings. So a comprehensive echocardiographic assessment was crucial in diagnosis of this setting. It is important to know that mitral valve has a complex structure. The 3D structure of the mitral valve is extremely important, and hence the 3D imaging is also very helpful in assessment and guidance. What are the contraindications for proceeding with transcatheter options? Assessment of the LA left atrial appendage clot, if there's any evidence of infective endocarditis, intracardiac device infections, hypersensitivity to the components of the prosthesis, rheumatic mitral valve disease, or if they have any venous thrombus in the IVC or the access site. It is also important to assess the feasibility in about 21 patients that they were studied out of close to 1,100 patients for unexplained moderate to severe mitral regurgitation. They were found to have clefts, which are now feasible for transcatheter edge-to-edge repair. So this is a 3D anatomy of the mitral valve. This is the anterior aspect should be always like associated with the aortic valve, and then the lateral is where the appendage is, and the medial is where the intraatrial septum is. As depicted, this is the surgical en-face view. For primary mitral regurgitation, the feasibility of transcatheter edge-to-edge repair is based on the anatomy. The segments, if you have a isolated A2/P2 scallop prolapse or flail with no calcification and a valve area greater than 4 with a low gradient and a flail width of less than 15 and a gap of less than 10, that's the ideal situation. And usually one clip can fix the pathology. However, as you progress through this algorithm, you get to severe Barlow's disease with multiple regurgitant jets and multiple grasping zones required, a smaller valve area and high gradient, then that becomes the anatomy more unlikely to get repaired with transcatheter edge-to-edge repair. And unfortunately for Our Lady, this is where she fell because of, although she has an isolated A2 flail, but she had multiple scallop prolapse. What about secondary mitral regurgitation? The data for secondary mitral regurgitation, as we discussed, is coming from co-op study criteria. And these patients should be on maximally tolerated guideline-directed medical therapy, NYHA2 to ambulatory 4, EF of 20 to 50%, end systolic dimension of less than 70, and then PA systolic pressure of less than 70. Those highlighted in red are exclusion criteria, and these patients then not meeting these criteria are not going to necessarily benefit from transcatheter edge-to-edge repair. So what about other techniques? We talked about edge-to-edge repair. How about transcatheter mitral valve replacement? Transcatheter mitral valve replacement is currently being under research trial in patients with native mitral valve regurgitation and not significant MAC. And then aortic bioprosthesis have been used in native mitral valve stenosis and patients with severe MAC, patients with a prior surgical ring, or patients with a bioprosthesis in the mitral position for valve-in-valve consideration. Overall, transcatheter mitral valve replacement has a very high success rate in mitral regurgitation elimination. However, the enemy of TMVR is a small neo-LVOT due to the implantation of the new valve and the dynamic LVOT obstruction. This highlights the role of cardiac CT in planning cases for TMVR. The role of cardiac CT has been priorly well explained in the setting of TAVR, for TAVR planning, for access site. So we're not going to dig into the role of CT for TAVR. We're going to focus on TMVR for the purpose of this talk. Cardiac CT improves pre-procedural planning and intra-procedural fusion imaging. It is important to have a good understanding of cardiac CT for proper image acquisition and phase reconstruction. Detailed measurements are required, and then using cardiac CT imaging, 3D modeling can be performed as well, using various softwares or 3D printing to improve TMVR success rate. So when a bioprosthesis is implanted in the mitral position, because the anterior leaflet of the mitral valve is getting pushed to the LVOT, and overall because of the angulation and other factors, the neo-LVOT tends to be smaller than the original LVOT. This can be predicted using various factors to exclude high-risk patients, because having a dynamic and a small LVOT obstruction is fatal. So if you focus on figure A, you can see that depends on the type of the bioprosthesis that's getting implanted. The height of implantation plays a role in the size of the neo-LVOT. The shape of the prosthesis is also important, with the conal shapes that's implanted in the mitral position are at higher risk of causing neo-LVOT obstruction, and also the aortomitral angulation. The aortomitral angulation is the angle between the atrial plane and the annulus of the mitral valve, and the ideal cutoff should be more than 115 degrees in these settings. Patients who have a more obtuse angle of less than 115 are at higher risk of having LVOT obstruction and a small LVOT. The other factor that's also very important is the shape of the septum. A sigmoid septum in combination with implanted prosthesis increases the likelihood of LVOT obstruction. A couple of patients with no other options in our facility underwent TMVR implantation, and alcohol septal ablation at the same time. And so far, both of them are doing okay. The cutoff that we use for LVOT, for neo-LVOT in terms of proceeding with procedure is around 1.7 to 2 centimeters, depends on various clinical settings. Cardiac CT also plays a crucial role in planning for patients who are undergoing mitral valve in ring, mitral valve in valve, and mitral valve in MAC. Again, the neo-LVOT size and the sizing of the prosthesis is dependent on assessments by cardiac CT. For patients undergoing valve in ring implantation, a detailed assessment of the ring is required by CT to size the prosthesis properly and also detect whether this is feasible to avoid paravalvular regurgitation and optimize prosthesis implantation success. Ideally, a semi-rigid ring which can adapt to the implanted valve morphology is the best ring. Other form of rings, including a rigid ring, an incomplete ring, or the ring that's not the ring that's completely is a rigid ring but not complete, increases the risk of paravalvular leak or unstable prosthesis. This is another example of the modeling that was performed to assess the angulation of the bioprosthesis in the mitral position to help determine the size of the neo-LVOT, these settings. And the CT was very much on par with the findings of what we had for post TMVR in these settings. Proper windowing is also very important. Proper windowing and using using like a bone window versus the angio window helps differentiate between the true ring and also improves the size of the bioprosthesis that require to be implanted, because the smaller size increases the risk of embolization and also increase the risk of paravalvular leak. What about valve for native ring? Currently, the Apollo trial is using the Intrepid valve to assess the feasibility of this valve in patients with native mitral valve regurgitation and no calcification. And there is another part and another arm of the trial that's using the Intrepid valve in patients with MAC. As we discussed, the enemy is that neo-LVOT obstruction, and the same holds true for patients who undergo Intrepid valve implantation as part of the Apollo trial. If the anterior leaflet is long, some of these patients require the anterior leaflet to be catheterized in settings and having a lampoon procedure performed. This is an example of a patient who underwent Intrepid valve implantation as part of the Apollo trial for mitral regurgitation. The top left image is the pre-planning. You can see the finger poking for a transapical approach as they're trying to find the apex of the heart. The top right image shows the valve that's getting positioned in the left atrium. The bottom left image is the implanted valve in the mitral position, and then the 3D imaging showing the valve well positioned in the left atrium with a normal function in settings. There was a study that was published recently by G and the group from Boston just last year, looking at the role of cardiac CT in pre-procedural planning. Overall, out of the 80 patients that were referred for transcatheter mitral valve replacement, 64% of them deemed not to be candidate due to the findings of incomplete anchoring from the MAC, inappropriate sizing, or a small LVOT size post, potential small LVOT size post implantation. Out of all the patients that underwent TMVR, 5 had major complications, and that was all because of the LVOT obstruction and a small LVOT. So when the sizing is performed, if the LVOT size is appropriate, then the software, the 3Bensio software or other available, commercially available software are using for valve sizing, and then the bioprosthesis can be sort of manipulated and adjusted for that specific setting. This is a case of a bioprosthesis failure that, as you can appreciate, has severe mitral regurgitation in the setting of flail leaflet. It's a very eccentric jet that was not necessarily picked up on the transthoracic echo, and then the TE confirmed the findings. This patient went under a transseptal approach for implantation of a sapien valve in the bioprosthesis mitral valve for a valve-in-valve procedure. You can see the deployment of the sapien valve in the prior implanted bioprosthesis. And this is the post-valve deployment with no significant paravalvular regurgitation or intravalvular regurgitation in these settings. So let's go back to our case. This is the CT of Our Lady that confirmed the bileaflet prolapse. The coaptation gap was huge, and further calculation for the neo-LVOT size showed that her LVOT size is going to be 0.7 centimeter post bioprosthesis implantation if she was considered for the Apollo trial. So we had a lengthy discussion with the patient and her family. High surgical risk, not feasible for TMVR, and so the plan was made to proceed with transcatheter edge-to-edge repair. So this is the transseptal approach with mitral clip placement over the flail segment, which was the A2 scallop. We performed pretty much 90% of the procedure with 3D imaging. This is the grasping of the leaflets. As you can see, the clip arms are open. Both leaflets are falling nicely into the clip arms. And on the right image, the clip is closed with a good grasping of the both leaflets. There is still quite a bit of mobility in the setting of bileaflet prolapse and Barlow's disease. This was the final results with no significant mitral regurgitation in this setting. And this is the Doppler finding that showed a mean gradient of 3 and no mitral regurgitation. And this was the assessment of her pulmonary veins, which showed systolic flow reversal initially with a systolic dominant waveform post-clip implantation. And aligning with all the other findings, this was a drop in her V wave from 66 to 19 post-clip implantation. This lady discharged 3 days later, uncomplicated, and at 1 month follow-up clinic, she was doing very well with no symptomatology. This was her echocardiogram at 1 month, which showed no mitral regurgitation with a gradient of 4 at baseline. So just to wrap up this case, there was a study that was published in October of 2021, looking at the feasibility of transcatheter edge-to-edge repair in patients with Barlow's disease. It showed that overall, immediately post-procedure, the rate of success is very similar to patients with isolated leaflet prolapse. However, long-term, there is an increase in the severity of mitral regurgitation in these patients, and that severity has been defined by being more than mild compared to a single leaflet prolapse. So I'm hoping that with this case, I showed you the important role of TTE, TEE, and cardiac CT in planning for a patient that does not have many options and ideally cannot be on medical management. I'm happy to take any questions before proceeding to the next question, to the next case.
So Payam, what happened with her atrial fibrillation? Was it corrected by the mitral clip?
Well, she had a history of like paroxysmal atrial fibrillation, and interestingly, like in that tracing that I showed, she was in sinus, so she was so far good.
Yeah, no, but I mean, in these patients, going into atrial fib, that's probably what triggered her heart failure and everything. So
yeah, like I've seen this lady once in follow-up. And since then, at least from what I remember, she's been currently asymptomatic, no issues. But I can't recall the detail of her atrial fibrillation, whether at this point it's like gone or not. Okay, so I'm gonna go. I think I have one question here.
yeah, maybe you can leave that one for the end of
yeah. Okay, so for the next case, we're going to talk about a complex aortic valve disease. This is a topic that you're gonna see more and more in the setting of advancement in technology and more patients undergoing TAVR. So this is a 76-year-old male that has a history of aortic stenosis, status post-TAVR with Evolut Pro plus 29 in 2019. He did not have any history of obstructive coronary artery disease, has a history of hypertension, type 2 diabetes. He presented with worsening dyspnea on exertion over the past 3 months, and on his exam, he had a harsh systolic ejection murmur. The one question that you want to ask yourself is that, okay, what's my differential diagnosis at this point? What are the things that you would like to know on review of system? However, because we're short on time, I tell you that his blood culture was negative. He's been always taking antibiotics for dental work, and his review of system was negative for any findings to suggest that this is an infective endocarditis. And this patient underwent an echocardiogram, which showed a normal LV systolic function, a normal VTI in the LVOT. However, assessment of the bioprosthesis showed a velocity close to 5 meters per second and a gradient of more than 50. This was the initial echocardiogram post-implantation of his TAVR valve that although showed a higher velocity than expected in this setting for the bioprosthesis valve, but there is a significant change compared to his baseline echocardiogram in the prior echo compared to this, especially in the setting of the velocity and gradient. His velocity was close to 3, and now it was close to 5 meters per second. So his clinical summary was, again, is a 76-year-old male with calcific aortic stenosis post-TAVR. He was a low-risk case in this setting who's presenting with dyspnea. And now he has elevated gradient across the TAVR valve. So what is your differential diagnosis, and how would you like to manage this patient? So differential diagnosis in this setting, valve thrombosis, infective endocarditis, potentially Pannus formation, or a valvular regurgitation that increases your LV flow in overall. However, no valvular regurgitation was diagnosed in these settings. Management at the end comes down to your differential diagnosis and the findings of further testing at this point. So this is the recent guideline from AHA in 2021 that basically in patients with prosthetic valve, a high suspicion should be given in the clinical setting for valve thrombosis. If you have a velocity of more than 3 and a mean gradient of more than 20, DBI, which is dimensional index, of less than 0.3, effective orifice area of less than 1.2. If the shape of the jet is getting to become more like a severe stenotic valve, acceleration time more than 80, or if there's a new transvalvular regurgitation. Findings of hypoattenuated leaflet thickening and reduced leaflet motion are diagnosed on CT, and then thrombus visualization is another findings that we can see on CT imaging in these settings. So this gentleman underwent a cardiac CT. You can appreciate that you anticipate the leaflets of the bioprosthesis valve to be thin and almost like not being visualized in this view. However, you can see the crescent-shaped thrombus formation in all the leaflets of the TAVR valve in this setting. The 3D imaging showed that the leaflets are restricted, they are not opening well, and so this gentleman was diagnosed with TAVR valve thrombosis in the setting of hypoattenuated leaflet thickening and reduction in leaflet motion. So what do we know about hypoattenuated leaflet thickening and reduced leaflet motion? This study was published in JACC in 2020 by McCarran and the group from Partner 3. And that showed that for SAPIEN valve in the low-risk group, there is an increased risk of hypoattenuated leaflet thickening at 30 days compared to the surgical valves. And this risk carries to be through at 1 year as well. Overall, 13% versus 5%, and at 1 year it was 28% versus 20%. At 1 year, this risk was not statistically significant. However, at 30 days, this was significant. Blanky and the group from the Evolute trial did not show the findings of worsening halt in patients undergoing TAVR versus a surgical valve implantation. There was a meta-analysis which was recently published looking at the presence of halt, the hypoattenuated leaflet thickening, and valve thrombosis. This meta-analysis looked at about 12,000 patients, and that showed that the prevalence of subclinical leaflet thrombosis and clinical valvular thrombosis TAVR valves is 15% for halt and 1.2% for clinical valve thrombosis. So it is, we know at this point that subclinical leaflet thrombosis has a high prevalence, it's about 15%. And in majority of the patient is getting not diagnosed. The same holds true for patients who underwent a TAVR valve implantation in high-risk group. Both the Edwards valve, which was the SAPIEN valve, and then the Evolut core valve showed higher risk of thrombosis compared to the surgical valve in patients who underwent AVR in high-risk groups. Age and the size of valve are predictors of subclinical or valvular thrombosis. So the older age and the larger the size of the valve is, the more the patient is prone to get valvular subclinical/clinical thrombo. What is the significance? Of course, symptomatology for our case was progressive dyspnea. However, majority of these patients present with neurological thrombotic findings, mostly TIA/stroke. How does CT can help in these settings? So findings of the leaflet thickening, also assessment of the Huntsville unit of the lesion, the shape of it, the timing of the formation and location is important. We know that a thrombus has a Huntsville unit of less than 90, and Panis formation, and Panis has a Huntsville unit of more than 145. The 90 to 145 range is the gray zone in this setting. Panis is predominantly circumferential compared to the irregular shape of the thrombus. Thrombus can occur at any point, but they are more common in the first year of implantation, and Panis tends to form later. And then we know that Panis mostly forms in the Panis forms in the LVOT side. However, thrombus can happen on both sides of the aortic valve prosthesis. Prosthetic valve thrombosis has been addressed recently by the Valve Academic Research Consortium. They categorize it to stage 1, stage 2, and stage 3. Stage 1 overall is the morphological changes with no hemodynamic significance or findings on the echocardiogram. Stage 2, which is the moderate, is an increase in the mean gradient of more than 10 compared to the baseline, or overall a mean gradient of more than 20. And change and the findings of the reduction in the effective orifice area. And then severe hemodynamic valve deterioration is the increase in the mean gradient of more than 20 with the mean gradient of more than 30 at baseline. And our gentleman fell into the category of severe hemodynamic valve deterioration in this setting. This is the grading for the hypoattenuated leaflet thickening. So if you have just base of the leaflet involved, that's less than 25%, less than 50% with a crescent shape is grade 2. Then as shown in this picture, more than 50 but not involving the whole leaflet is grade 3. And then in our setting, this was a severe, more than 75% involvement of the leaflet, all 3 leaflets in these settings. The hypoattenuated leaflet thickening and subclinical thrombus formation can cause reduction in leaflet motion and subsequently worsening the degree of the aortic stenosis. Timing of it, it can happen pretty acute, subacute, late, or very late. And in this setting, it happened very late in our case, which was more than 1 year. As we discussed, the clinically significant valve thrombosis is any hemodynamic valve deterioration in stage 2 or 3, confirmatory imaging findings, or if they have any clinical presentation, including thromboembolic events in these settings. We discussed this algorithm before, but it's important to understand the role of 3D TEE and CT in assessment of patients with subclinical valve thrombosis, as most of these patients have an undiagnosed pathology at this study. What do we recommend for prevention and management in these settings? So if the diagnosis is confirmed, these patients should be on anticoagulation. However, unfortunately, we do not have good data for duration of anticoagulation in these settings. Anticoagulation should be ideally with a vitamin K antagonist. The data for NOACs are neither here nor there, and therefore they have not been widely used. However, some of these patients are on NOACs and they respond well to therapy in these settings. So this gentleman was actually put on apixaban for 3 months, and then he presented for further follow-up. And this is the findings of the echocardiogram. You can see the Doppler jet on the aortic valve dropped to about 3 meters per second, which was close to his baseline. And this is the finding on his repeat CT 3 months post anticoagulation with almost complete resolution of the thrombus over the leaflets. This is again 3D CT images of the valve. You can appreciate the valve opens much better, and the leaflets are almost invisible in these settings. HALT and subclinical thrombosis doesn't have to be that extensive. It can happen in one leaflet, as you can see in these settings. And also CT can be helpful in assessment of thrombus formation in patients with mechanical thrombosis. This is a case that we recently published for a mechanical valve thrombosis that could not be detected, and finally cardiac CT showed the thrombosis in this setting. So remember your clinical features in these settings: new onset heart failure, any thromboembolic events in these patients. It requires to have high suspicions for aortic valve dysfunction or thrombosis formation, and we discussed the algorithm that is required for these patients for further workup. Consider TEE and CT assessment in these settings if there is high clinical suspicions. Prosthesis valve, as we discussed, they are common. At this point, TAVR is getting more and more popular, and therefore prosthetic valve dysfunction is also common. Advancement in multi-detector CT improves clinical outcome, as we discussed. And remember that TAVR valves are more prone to subclinical thrombosis compared to surgical valves. HALT is a relatively new entity, which is I cannot emphasize more. It's it's not getting diagnosed as frequently, and so the role of multimodality imaging is important in this setting. Any questions for this case? So I'm going to briefly talk about the importance of heart valve team. I hope that I convince you that detection of valvular pathologies is difficult, especially if you do not have the clinical suspicions or the expertise in imaging. A dedicated valve structural team improves diagnosis. It helps with decision-making, procedural planning, and follow-up of these patients. The structural field is growing very, very rapidly, and the need of a dedicated heart valve team in a tertiary care center is extremely, extremely important. The question is, are we You can have a different type of orchestra, like, people can do their own thing, and there is no synchrony, or you can have synchrony and a proper orchestra in these settings. Overall, interventional procedural imaging play a huge role in terms of being the quarterback of these settings. I'm going to skip this. We specifically talked about TTE, TE, and CT. CMR also plays a huge role in assessment of the valvular pathology and quantitation and like the assessment of the severity, and overall the role of imaging. We know that it's complementary in these settings. We have 3 versions of the valve guidelines since 2014. We have multiple guidelines, and that's been published by the American Society of Echo for CMR for echo. Mixed valvular regions, LV systolic dysfunction, and prosthesis assessments are getting more and more complicated in these settings, which advocate for a dedicated heart valve team in these settings. This is the example that I showed before, which can easily get misdiagnosed as a mild mitral regurgitation when in fact the patient has severe mitral regurgitation. This is the component of the heart valve team that we have at this point. We think an interventional structural imaging cardiology is key. Interventional structural cardiology, group of dedicated cardiovascular surgeons, nurse practitioners, and that all works in conjunction with heart failure clinic to make sure all of these patients are on optimal guideline-directed medical therapy before getting referred for further interventions or procedures. Outpatient valve clinics are crucial, and then in-hospital consult teams are also extremely helpful in these patients. Putting all this together, that end up to have a need for a multidisciplinary meetings to discuss these patients' details, to make sure all these patients have a unified and concise approach to their care. And I would like to thank you for giving me the opportunity. I hope you find the talk useful, and I'm happy to take questions.
Thanks, Payam. That was a nice overview. So let me ask you something. So what kind of volumes are you guys doing there for, mitral valve and aortic valves?
So for TAVR, at this point, we do pretty much TAVR on 3 days of the week, between 6 to 10 TAVRs a week. For mitral valve transcatheter edge-to-edge repair, we do about 2 to 3 a week. And then I would say for TMVRs, at this point, it varies, but I would say it averages maybe 1 or 2 a month. Most of the TMVRs, though, are the SAPIEN valves in the ring, in MAC, and in bioprosthesis. The Apollo trial is currently ongoing, and we are a site for Intrepid valve, but you may have a month with 3 cases, and you may have 3 months with no case.
And that valve clinic runs like twice a week, or how's that work?
So the valve clinic here actually runs 3 days a week, 3 half days a week with different physicians, like the imagers, interventionalists have the valve clinic, and those are like the ones that are doing the procedure and doing the pre-procedural planning and intra-procedural guidance. And then we have the dedicated cardiovascular surgeons, and specifically Dr. Reardon, who's seeing most of these patients. Michael Reardon is the one who did a lot of the TAVR studies, including the Evolute, low risk and high risk. So he's the one that has been very much involved with the valve team, but we have 2 other surgeons as well that are seeing the valve patients. So it works. All of the valve interventions in our facility are getting cleared by the multidisciplinary team of the interventional imagers, the structural interventional cardiologist, and the cardiovascular surgeon that are meeting once a week.
So there's a bunch of comments from one of our surgeons that, what's the post-op follow-up? And is there a dedicated structural heart post-op follow-up? And where there are 2 teams, mitral and aortic, given the complexity and differences between the procedures?
Yeah, so all of these patients from a follow-up perspective are coming back to the Valve Connect 30 days post-discharge. If the needs is there for them to be seen sooner, then of course they can be seen sooner. For our TAVRs and mitral interventions, if there is no issues after 1 month, then they go to 1 year. But at this point, this has sort of been the trend for both aortic and mitral. But the team, the in-hospital valve team follows the mitral ones more closely, and we tend to see them more frequently if needed. The aortic ones are getting more straightforward, as mentioned by Dr. Adam.
Okay, well, that's great. Well, Payam, thank you very much. That was a great presentation. And stay cold, because you're too warm down there. Take care, eh?
Thank you very much. Appreciate it. Thank you, everyone.